afternoon. Welcome to the Hospital of the Future 360 webinar series. This is the number 7, I guess. And the topics of today are going to be interoperability, platforms, and data spaces. The chairman of the webinar today is Giuseppe Fico, and I give you the floor, Giuseppe, to start with a presentation of the speakers and then launch the webinar. Thank you.
Welcome, everyone. It's a very great privilege to have you here for this series of the ODIN Webinar of the Future. And I'm very honored because, well, I'm Giuseppe Fico from Universidad Politécnica de Madrid, and I'm the technical manager of the ODIN project. But today I'm here for a very interesting webinar because we are putting very important stakeholders in what we all call the digital transformation of our healthcare systems. And so as you are going to see, they are basically representing 3 important perspectives. Yiannis Stolias from the European Commission has been working and is part of the team on the legal aspect and artificial intelligence team related with the European health data space. Yiannis is going to join us in a few moments. The second presenter will be Catherine Barras from Daedalus. So we are going to have the industrial perspective. Daedalus is an important and big player on healthcare system and their digitalization. So we are going to hear about the role of the digital platform in this transformation. And finally, we are going to hear the voice from public healthcare organization. Catalonia is a very interesting region in digital transformation, of healthcare systems. It's always been a very innovative region in all these aspects. And we have the privilege to hear the opinion on this topic from Jordi Piera, who is a key person in the digital transformation of the healthcare system in Catalonia. And you can see here from the title that we are going to hear some important message. So we are going to have, these are the timing for the presentations. We would like to leave some space for discussion. You can pose questions in our chat. And with no further delays, I'm really happy to give the floor to Dr. Yiannis Stolias. Yiannis, the floor is yours. I will start sharing and you can share your screen whenever you will.
Hi, nice to see you all. Sorry for this delay, I was in the other meeting, and let me share my screen. So as I said, now as we all know, there is abundance of health data, plus advancements on artificial intelligence, and this is the 2 combined together could potentially transform healthcare. Of course, this is an interdisciplinary collaboration. There is the engineers who should do their part of the work. There is other people, let's say, from ethics angle, from legal angle, from the policy angle, and so on. Now, I will refer to the 3 concrete steps that the European Commission has taken with 3 legislative proposals, which I think they could be interconnected. This is what I will try to also indicate, but also showing how they could be advancing this digital transformation, what rights and obligations could be creating to different actors within this framework. As you all know, the AI Act was adopted by the Commission in April 2021. Now it's discussed at the European Parliament and the Council. So I will refer to its original version. Of course, now we don't know how it will be amended, but that's the proposal. I will refer to it. Then we had the European Health Data Space, which was adopted in May 2022. And also yesterday, actually on the 28th of September, we also had the liability proposals by the Commission, which is 2 directives proposed. One of them is the Product Liability Directive, and the other one, the AI Liability Directive. So I will touch a bit on that one. Maybe it will be interesting if we had to separate at some point, maybe in the future discussion of more detail on liability. But I think the three could be nicely interacting with each other and affecting each other. Let's start with the, as I said, the legislative contribution on this debate of digital transformation. First of all, the legislative contribution aims at individuals, empowering individuals to have access and control over their personal data. Then it also affects healthcare professionals because it creates obligations and rights on healthcare professionals. On the researcher, now I'm going to the right-hand corner. Can you see my cursor, by the way, so I can be showing, or?
Yes.
You can see it, great. So we see here the researcher, so how you could be using data for research, development, innovation, and so on. Then once you produce a product, of course, to really deploy it and to really create trust in the products, especially, let's say, AI products, you should ensure they're trustworthy. And again, this is what the legislative proposals provide. And finally, which is also of particular interest to me, is this development of a collaboration between the clinician and AI, which could be, especially in healthcare, it could be an interesting aspect and challenge to also address, which is also indirectly addressed through the legislative proposals. So let's start with the EHDS, the European Health Data Space proposal. We said you give rights to individual. What does it do? First, it creates the right to be able to immediately, free of charge, and easily readable form accessing your data. Of course, we had these rights in the GDPR, but they were not so concrete. In the General Data Protection Regulation, you had the right as individual to be accessing your data, but as you know, you had to make an application. It could have taken 1 month. You should have gone to the controller to give you access to this data. However, with the EHDS, we create a GDPR plus because the right should be immediate. That's one of the new, if you want, aspects that are addressed. Then in certain categories, and I will come back to the priority categories, you could be getting them in a special format, what we call the European Electronic Health Record Exchange format, which will ensure interoperability. That's also the other big thing there. Of course, there will be also data which are not registered electronically, especially before the application of this law. The member states, there is a provision which says that the member state may require this data to be transformed into electronic format to basically digitize all those all those data which are not electronic now. The individual could also restrict access to their data, and it could also have, again, this is a GDPR plus, right? That you can not only know who has access to your, not in general that hospital access your data, but you could know which doctor access your data, so which specific person has access to your data. Now we go to the healthcare professional. The healthcare professional should be able to access all data under their treatment. And of course, this would help, especially, for example, in the case of telemedicine, even cross-border. You may go to another, to teleconsult another doctor in another member state. I'm in a small village in Europe. I want to consult a specialized center somewhere else in Paris, let's say. I would be able to teleconsult, and the physician would be able to have access to my data and see all my data. So it will boost up also healthcare and digital, even telemedicine in that aspect. Then the healthcare professional should be ensuring that the data are updated, of course, for the patient to have access to it. However, there is another interesting aspect there, that you create this obligation for the researcher, because if you don't have updated data, then you won't have good data to be used for research later. So I think that also helps research, that you create this obligation on the healthcare professional to continue updating the data of the patient. Then in certain priority categories, you should ensure as a member state that the healthcare professional is having access to your data from the health professional access services. And as I said, there is priority categories that we have identified in the EHDS, and this should be the patient summaries, electronic prescriptions, electronic dispensations, medical images and medical reports, laboratory results, and discharge reports. These are the priority categories that we started with. Now, another part of the EHDS is the electronic health record. This one we are creating basically a CE marking, which means what? It means that all electronic health records would need to be CE marked, which means that they need to abide by, they need to comply with certain requirements before they're allowed to be placed on the market. Of course, this one creates some obligations on the manufacturers on the one hand, but on the other, it ensures that if you develop a product or a service like the electronic health record, you would be able to deploy it anywhere in Europe because the requirements should be the same without facing any obstacles to trade or to put the product into service. So you would be able to have these rights. So it creates, if you want, a single market for electronic health records. And again, what it would be contained, it will be the priority categories, as we said those before, those 6. And there is an annex in the European health data space, which mainly it governs, there would be some general requirements, some interoperability requirements, because that was one of the big things, that these electronic health records will be also interoperable. And since it will be a CE mark product, it means you would be only allowed to buy the CE mark products if you're a big hospital. So it means that immediately, if you buy these products, they will be also talking to each other. They will be also interoperable. And thirdly, we have some security requirements, cybersecurity requirements. Of course, these cybersecurity requirements are added up because a few days ago, there is also the Cyber Resilience Act, which was proposed by the Commission and will be also applicable to electronic health records. So we're also ensuring cybersecurity. Now, another interesting aspect that we're trying to do is to create interoperability between the medical device, the AI system, and the well-being apps. And there is provisions there of how you could, if you are claiming interoperability, especially with the first 2, you have to comply with section 2 of the Annex 2, which basically is interoperability requirements. And the idea there is that you will be easing even burdens from the physicians, because I guess if you're a manufacturer of, let's say, a medical device, you would want it to be interoperable with the electronic health record. So you would, even as a marketing technique, you would want to do that one. It's not obligatory, but if you wish to do them interoperable, then you have to comply with the European Health Data Space Annex 2 on interoperability. So that's the same thing with AI systems. As I said, there would be maybe an incentive, a market incentive to create interoperability, or even hospitals might be requiring that they want to be getting interoperable medical devices and AI systems. So that's how it connects. With well-being apps, because we didn't want to impose too much of a burden, this is not an obligation, but you may be accompanying it by a label claiming basically if you use my AI app, you will be also able to interoperably transfer the data in your electronic health record to your physician. We'll see, of course, how these negotiations now, the Council and the European Parliament, take place, but that's the idea on the current draft. Now, let's go to the researcher now, and let's get the data holder, which could be a hospital. Of course, the data holder, it doesn't mean it's only a hospital, but I'm getting the example of a hospital just to make the story. So if the data holder now is a hospital, and the hospital is using them in this box, processing data for certain purposes, for example, provision of healthcare, which it would be yes for the hospital, and it will be a minimum category, and the minimum categories are mentioned in Article 33, which is, for example, what you have in the electronic health record, genetic, genomic, general data from medical devices, well apps, and so on. So if this type of data are in the hospital, they have been processed for certain purposes, then you would be obliged to make them available for research. Let's say for research, for other purposes too, but I'm just using research now. Now, the data user, which will be the researcher. The data user now would think, do I want to use data for education, scientific research, training, testing, and evaluating algorithms? You see, we made here also a connection with the AI Act. That's why there is also these express provisions there, because when we're drafting it, we wanted to make it also closer to the development of AI. So do I want to develop AI systems, basically personalized healthcare and so on? If the answer is yes, there is also prohibited uses, let's say for insurances, to stop insurances of people and so on. These are prohibited. But if let's say you want to use them for those purposes, then you can send a data access application to your data access body. There would be one, at least one in each member state. If you send your application, the data access body now would check, does this researcher require data for the right purposes? Yes, let's say. If yes, you should be able to get anonymized or pseudonymized data depending on some requirements there. If, for example, anonymized wouldn't be good enough for you, for your specific research and so on, there would be exceptions to get it in pseudonymized formats. Now, of course, as a researcher, you might want to get not only from your member state data, but cross-border. So you could send a single application to your data access body, and the data access body will transfer your application everywhere else in Europe. Sometimes as a researcher, you might not want to get in general data, but you want from a specific data holder because you know that that hospital is what you want. You could also send what we call a single data holder request to that specific hospital and then you have a direct collaboration if you want, or a direct connection with that hospital under the provisions there. Now, all this data, you won't be send your data to your lab, but all this data would be processed in a secure processing environment. So now, if I have a few more minutes just to tell you a bit about the secure processing environments. Of course, in principle, you could be accessing secure processing environment for members, let's say in Finland, if you want to use data from Finland, in Sweden, if you want to use data from Sweden, in Spain, if you want to use data from Spain. Of course, that could also mean costs because you will be paying for accessing those and organizing those secure environments. So you may be asking, why don't we have one joint secure processing environment where Sweden, Finland, they could throw them in there and I could, as a researcher, go there, or an EU one, and do my research there and then get out of the processing environment. And then, of course, this data would be deleted afterwards. But you won't be getting them, as I said, in your lab. You have to be going in the secure processing environment and using those. The answer there is not, we have not specifically said how it should work, but in Articles 50, it provided technical requirements of the secure processing environment. So in principle, it could be even private ones, as long as they comply with those requirements, and the commission will be auditing them and so on. So how it will work is not specifically mentioned. However, the technical requirements are mentioned. Now, data quality. Data quality, if you're a data holder now, as we said, you are obliged to be sending your data to the data access bodies, so researchers could be coming and having access to your data for research, education, and so on. Under Article 41 of the HTS, you should be also providing a general description of what data you hold, and the commission could be issuing minimum requirements of what you should be sending. So you would be saying, I hold, for example, cancer data, and these are the general description of the data I'm holding them. And you send them to the data access body, the DAP. You could be also, I don't know why you want to do that thing, but you may also want to issue a data quality and utility label, basically saying that I have good quality data. It could be also useful for you because you want the people to be accessing your data. If you want to do that thing, that data and quality utility label, I will come back to in a minute. But this is your obligation. This is not the obligation. Now the TAP there, they should be also issuing what we call a metadata catalog, so the researcher would be able to see what data you hold. Of course, another DAP let's say this is the Finnish one, this is the Spanish one, would be also issuing a catalog. That's why the European Commission should be joining the catalogs and creating an EU catalog, so the researcher would be able to access this EU catalog to see exactly what is happening within Europe, what data exists within Europe. Now, data quality and utility labels. If you are now having data from different sources and you send them to the DAP there, you may have a data quality and utility label. It's not obligatory. However, if your data have been processed and you have been funded by the member state or by the European Union funds in processing the data, then you would be obliged to have a data quality and utility label. Basically, if you got funding from member states or the EU. This data quality and utility label, now we have, for example, issues on biases, accuracy, uniqueness, data enrichments, and so on. Of course, at this point, you may ask, how do we define really bias? How would you really define what is the meaning of bias? That's why Article 56.5, it says that we may have to develop standards to define all these things. And of course, there could be questions on, would you go to third-party assessment? Would you self-assessment? How would you connect them to the biases which are mentioned, let's say, in the AI Act? And all these things would be dealt with at the later stage through common specifications. And this is what Article 56 provides. That's the idea there. This is the infrastructure, but I'm going a bit fast. Let me see. Sorry if I'm taking, I think I took a lot of time. So maybe another 2 minutes, if I may have, just to give you a bit the connection with the AI Act.
Perfect. Thank you.
Yeah, the AI Act, and I will focus only, of course, it ensures and it aims to have systems which are trustworthy. Of course, there is different requirements, but I'm just focusing only on Article 10, which refers to data and data governance. And there it says, for example, that when you're developing an AI system, your data should be representative of the geographical, behavioral, and functional setting in which your system is intended to be used. And also you should examine biases. As you can see, and this is again my own thinking, and we'll see how at commission level this thing will be developed. So this is my personal opinions now. I think there should be a connection now between the European data space as to what we mean and define bias there as to what we mean and define bias in the AI Act. Because that I think would help also the researcher if we have a data and quality and utility label there which fulfill certain bias requirements. I think it will help the researcher to be saying that I got the data and quality utility label from the European Health Data Space, so I'm immediately fulfilling my obligations under Article 10 of the AI Act. So I think the more connections we make there, and this is what I'm marking also bilateral discussing with colleagues within the Commission, I think we have to make all these connections to help, as I said, research, innovation, development of AI. Now, development of a clinician AI collaboration, I don't want to get into the details, but there is some provisions in the AI Act, like human oversight, like transparency, explainability, risk management, that you have to know the environment in which the system would be used. All these issues, I think, again, would be creating an interesting, it would be indirectly, at least, of course, it depends how we define them, how they should, the AI should be collaborating, especially in medicine, that, as you know, we have standalone software rather than robots performing, for example, operations. So you will have this continuation. And just one word on liability, which was published, I said yesterday, there is two legislative proposals. One, the Product Liability Directive, the other, the AI Liability Directive. And if you check those, maybe we'll have the time to discuss them at the later event or in the future, maybe another workshop. There is, again, some interesting stuff on this or collaboration, I would say, between AI and humans. Because at the end of the day, what is liability? Liability also dictates a certain type of behavior. Of course, we say liability, what happens if you suffered an injury, but if you see the bit of more academic theoretical level, liability would be also imposing and dictating how different people should be behaving, how the physician should be behaving, how the manufacturer should be behaving, and so on. And so I think the potential and the challenge is how do we combine all these legislative proposals to create this potential that we talked of at the beginning. Sorry, I went a bit too much. Thank you.
Thank you, Yanios. But I think we are all very happy to have given you these minutes more, because there is a lot of complexity in the European health data space. We are discussing that in many fora, and having some guidance and also opinion from your side is definitely useful. So I would ask to all the attendees to pose questions in the chat. We are collecting them and make them at the end. So with no further delays, I will leave the floor to Catherine Barras from Daedalus. So now the industrial perspective.
Good afternoon, everyone, and thank you for this invitation to present in this very interesting webinar. I've been following with great interest, as we do in Daedalus, the European Health Data Space Initiative and all these new acts. So we are really looking forward to see Europe accelerating and catching up to the US, especially other places in the world on this space. So what I'd like to share with you now is position basically the role that we see in what we call new generation digital health platform, supporting the overall healthcare transformation, because obviously all of these data-enabled health is to support a transformation which will enable our healthcare system to be sustainable on the long term. As we all know, we have some big challenges currently and ahead of time. So just to start and to perhaps reposition the fundamentals, obviously in our ecosystems, and this is, I know ODIN's project is really centered around hospital, but hospitals are at the core of the healthcare ecosystems. And obviously, probably all of us are familiar with the 4P medicine, which was defined in 2013. Just for the reminder, we have the P for predictive, which means basically indicating the most appropriate treatment for the patient, improving outcomes, but also minimizing the negative drug reaction. So anticipating the issues that could arise. Preventive, because it aims to anticipate and prevent health problems, focusing on well-being, on lifestyle improvements, or on screening. Participatory, because it means the patient should be more responsible regarding their health and their care, and personalized, obviously, because it takes into account not only the genetics or protein profiles, but as well behaviors or personal situation. And what we see is we're seeing more and more adding a fifth P, which is really the proof or the evidence of medicine, which is nothing new, but that's part of the things which are really in the dimensions to be handled when it aims to focus on data-driven medicine. And the 6P, which is basically pivoting towards the continuum of care and having plural care pathways. So basically, to deliver this 6P medicine, the healthcare sector overall is pivoting towards a more integrated, a more connected model across this continuum. And that means, and that implies a more structured collaboration of the different actors. And that really requires a 360-degree view of the patient. And that means it starts with the patient at home. Let me just put my pointer. Yeah. So it starts with the patient and citizen at home, given an active role. And we saw that in the previous presentation, how this connected device and this personal app would enable the patient to be more informed, engaged, autonomously managing their disease. Obviously supported by the community, the primary care, the social services, in particular for the patients with chronic disease with a population health approach. And obviously at the center, and for the sicker patient, the hospitals, who play a central role in this ecosystem, but especially with the growing focus on innovation and research, and as well acting more and more as advisors in a transverse way. So basically, to reach this 6P medicine, there are a range of hurdles. The structured collaboration requires data basically at the core, data as the new currency, with a lifelong value. However, challenges range from the lack of common data models today. Very often data have different syntaxes, or they have proprietary standards, which makes them very difficult to exchange. There is a challenge around the lack of semantic interoperability. Even if the syntax is identical, the coding or naming of medical concepts are multiple. And that means it's difficult to exchange information between professional tools and EHRs. But there is this overall lack of openness, which is a key issue, vendor lock-in or incoherent interoperability to tools, and overall a lack of data portability that's really resonates with what we need to address, and we see is at the core of the European health data space legislation. As Daedalus, for us as an industry and software editor, we have been really focused to work and exit this vendor locking situation for our softwares, and we have been I think one of the first vendors in the world to really promote open platforms with data stored in an open standard, making them fully open for exchange. We have as well, I was talking about the 360 view needed, but today we know that it's not the case. The data are still held in multiple silos. We have challenge on innovation. It's difficult to connect new apps, innovative apps, or connect new AI models because the data are not just, for all of the reasons mentioned before, but as well the connectivity through standard APIs is not yet there. And overall, finally, the rigid models make it more difficult to adapt to the change of workflows or connecting new systems, because we know the healthcare ecosystem is continuously evolving in how it's being configured. So overall, we see this big transformation happening in the healthcare system. We see integrated and coordinated care. We see population health becoming really a strong focus and emerging. And to facilitate this value chain, we believe that we need new generation platforms that will connect the ecosystem in a faster, in a more flexible way, which means the data will be stored across the whole ecosystem, enabling the connection for the patient, for the clinician, and enabling to improve the processes, but deconnecting the data basically from, not deconnecting, but enabling the common view of the data in complement to the individual systems. So that means we need to look at different usage of data and different profiles in the platform. There will be primary health usage for direct care or for proactive care or screenings or anything where the patient is engaged. And there are multiple examples. For the sake of time, I won't get into all details, but we could come back if we have time for questions. And there is obviously the very big landscape about the reusability of data, the secondary use, starting with the re-stratification for population health, but the overall operational requirements, which are becoming more and more key to optimize care, to reduce waiting lists, to basically improve the efficiencies in the system, and obviously the very important research and innovation domain. So the way we position new data platforms is basically to enable the liaison between the existing business systems, whichever they are, whether it's within a single hospital or a group of hospitals or within a healthcare region or even on a larger national level, to then position the platform where we look at having this API connectivity, where you can have we use 6 different steps to basically handle the data from the simplest to the most complex, starting from the integration, the ingestion, indexing, adding insight, connecting AI model, providing visualization, enabling the data exploration, and then enabling action and intervention. So I'll come back to that in more specifics. And then we bring in on top what we could call this new systems of engagements, whether it is new types of patient portal or front door to care, as we tend now to see the name emerging, or telemedicine, or various analytics or visualization tools, as well control centers. The pandemic has shown the need and some starts of emergence to have regional control centers in a number of countries, or just an innovative apps garden, basically, that you can connect. And this basically to support all end users. And it obviously, depending of the country, depending of the cultural sensitivities or regulatory sensitivities, on either on premise or in a version of cloud. So if I zoom on the 6 dimensions that I've shown, and really moving from the least complex to the most complex treatment of data across the life science. And again, this is something that we are aligned to in terms of our approach with our platform offering and our conversations with clients. So the starting point is really the first mile to get the data, to connect and integrate the different data. And here there are multiple ways to do that, whether it is for secondary use or for primary use. But what is really important is that we look at real time, because whether it is for secondary use from a decision-making standpoint, for clinicians to compare their patients with broader cohorts, for management to look at the status of queue or waiting list or clinical quality, or whether it is for direct care, real time is now the key. Secondly, having the data ingested into this integrated 360-degree view of the patient in a standard way. So in Daedalus, we have chosen the FHIR standard because it's really the successor of HL7. It's what is at the core of the exchange between our various systems, whether EMRs, lab systems, care coordination systems, and so on. So there is really here, through the integration, a big cleaning, alignment, standardization and homogenization of the data before storage. There is as well a FHIR API to connect to the external world. And since we know that there is not just one standard in healthcare, there are multiple standards out there, whether it is OMOP used for research or whether it is Open EHR, which I think we'll hear more about perhaps in the third speaker. There has to be bridges to open standards, and that's one of the big topics that we are focusing on from a platform standpoint. From an analytics standpoint, it means as well being able to augment and index the data, to map the data semantically to other standards. So if the data are in ICD-10, to map them on SNOMED CT or OMOP, and so on and so forth. And all of that basically having an API gateway to connect to the external world. We move into the more complex domain, and then we have the data augmentation, connecting with AI partners and tools, enabling new tools for data scientists to do more advanced cohorts extraction and enabling to do AI modeling and AI training. So that's another layer that platforms have to connect to. And just missing the reminder, the next level being the visualization for cohorting and clinical investigation. And finally, and very importantly, and that's where we are in the most, I would say, advanced layer of a platform in the vision, having actionable services, whether it is for example, a CDS hook to provide decision support, but as well to have workflow enabled push of notification to the patient, to the clinician, and basically having a closed loop. So to conclude, I want to explain that, this seems obviously a long journey and a lot of components in the journey, but these platforms already exist, they are already deployed, and they are already in operation. And I'm giving you here a range of examples of what we've been working on. Starting with, for example, very large integrated academic health system, New York Presbyterian in the United States. With this client, we have deployed the platform, and there is in the FHIR server dimension of the data to provide a transverse view, the 360-degree view of the patient, to enable what is called the front door to care, which is both a new generation patient portal, but as well a patient relationship management system, especially because in the US, they have a big recovery program post-COVID to get the patient back into the hospitals. The other dimension is the innovation. In 2020, the hospital was hit like everyone else with many staff getting sick prior to any vaccine, and getting organized was a big headache. So that we deployed in 3 weeks an app to really enable employees to find the nearest testing centers and for management to do the resource monitoring. Other example, and I'll just speed this up because I know we're out of time, Royal Papworth Hospital, #1 for heart and lungs in the UK NHS. Here we are in the secondary data usage. This is all about, the same detailed data extraction, very in-depth number of FHIR resources, enabling the researchers and the clinical trial coordinator to dig into the data to create cohorts with fine inclusion-exclusion criteria. And basically, this is the same foundation that we are using now in conversations about population health, but on a broader scale, on a regional scale. On the region scale here, other model, integrated care pathways for breast cancer, colorectal cancer, but as well rare disease, as well diabetes. So we have several pathways we support in region Puglia, connecting with various systems. There is remote monitoring. So here we have the integration with medical device that we talked about, integration with the local ecosystem. So another example. And the last two are really large examples. So in Egypt, we use the same platform to support the rollout of the overall universal health insurance and the overall equipment of more than, in these 6 governorates, 350 hospital clinics and primary care organizations for 5 million citizens. And this is really providing for the Ministry of Health both a nationwide set of clinical and operational insight, again, looking at data stored in FHIR standard. And finally, in Apollo, this is about systems modernization. And this is about a platform across the 70 plus hospitals across the country and hundreds of clinics to enable to provide new modernized applications to the clinicians, but as well to enable to share data with the patient. So just a few examples. We could obviously say a lot, but I want to wrap up and to hand over to the next speaker. Thank you for your attention.
Thank you. Thank you very much, Catherine. I think that also in this case, we gave you more minutes, but because really enjoying this vision. I'm receiving messages right now from many people for the 2 presentations. So we really were waiting for such a content from 2 interesting perspectives. So since we want to have also to give our time to Jordi for having the public healthcare perspective, I'm going to give you the floor, Jordi, right now. Please, again, don't be shy, make your question in the chat, and we will try to wrap up with some final comments given the time passing.
Okay.
So, Jordi, we can see you and the screen.
Good, thank you. So, well, first to say that to thank you, Giuseppe, and also Odin for inviting me. And also, well, it's been truly an honor to be speaking after Janos and Catherine. Amazing presentations and very powerful and strong messages. I like a lot what both of you explained. So, well, I came with this presentation a bit with well, this challenging title, and I just want to talk about well with you about a couple of things. The first one is to truly talk about health data and how we from the public sector see well, tackle this issue and which is our current situation. I would say not just from the service provider perspective, so the hospital, the clinic, but also from the regional / national system. And then the second part is, well, to talk with you about the future and which are the things that we foresee or that we are trying to make happen for a better future, I would say. So starting with the first part and talking about health data. First, just trying to give you the view of the hospital, which I think is possibly the biggest factory of healthcare data. It's a complex ecosystem of applications and solutions in which around the hospital information system, we have many different components / applications. So ranging from the biobank systems, the genetic systems, all sorts of laboratory systems, also the research data, and well, a growing myriad, I would say, of medical devices, all of them being part of this hospital information system. At the same time, and I think everywhere is the same, we have the situation that healthcare systems have been trying to move the boundaries from inside of the healthcare facilities to the patient's home, and this is making us to, I would say, dramatically increase the amount of systems that are now interacting with the hospital information system. And we have the mobile health apps, we have the telemonitoring solutions, and we have all the wellness devices and all these different things. We want them to be connected with the hospital information system. And we must acknowledge that this is something which is posing us and a great challenge, I would say. Obviously, the pandemic meant a huge, I mean, it has, or we must acknowledge that it had positive effects in terms of the digitalization of our healthcare ecosystem. It's sad at the same time that that we needed a pandemic for this to happen. But the question is that we had also an increasing amount of different systems interacting with the already overloaded hospital information systems. And well, here we have an article which is somehow letting us know about the technologies that were developed in the context of the COVID-19 in order to help somehow mitigate the effects of the pandemic. Then I wanted to give you, and I'm using the example of Catalonia, obviously, because that's what I know the best, and it's what is closer. But I think it's quite representative of any other healthcare system out in there. And it's when we try to connect all these systems, let's call them the electronic medical records, doesn't matter whether they are from primary care, from specialized care, intermediate care, community mental health, which is systems that, at least in this country, not just in Catalonia, but also in Spain, we started their implementation between, I would say, mid-80s and during all the 90s, when we are trying to integrate all the information, all those crazy amount of applications that form these systems, to some sort of shared electronic health record. So at the hospital level or at the clinic level, we maintain the systems. Systems that, as you can imagine, are getting a bit old-fashioned, and we are trying to plug them into this shared electronic health record. And in Catalonia, we've been, I would say, front runners in this area. And since year 2007, we've been, through interoperability and through interfaces, we have been connecting all these systems into a shared electronic health record of Catalonia. This is different for other regions in Spain, in which most of them, not all of them, but most of them have just a unique system for all the region. In Catalonia, we have, as you can see, more than 29 different products for hospital. In primary care, we are lucky that we almost have just one system. And intermediate care and community mental health, well, it's plenty of different solutions. But for us, the challenging situation is in all this interfacing, and I will let you know why. We have done some calculations, and this links a bit to the presentation from Catherine. I mean, we've been doing some calculations in our ecosystem, We surveyed some of our hospitals, either big tertiary hospitals or small secondary level or second level hospitals. And we realized that in a big tertiary hospital, we may have more than 800 silos of information. This means that the information related to the patients that they are treating in that specific hospital is split among these 800 silos. And we have to integrate this information locally, but then we have to integrate this information at the regional level in case we want to give some sort of continuity of care when this person is moving across the public ecosystem. In a second level hospital, well, the drama is a bit smaller. There's not the big amount of medical devices and I would say small gadgets, but still 400 silos of information, which is quite a big number. And all in all, I mean, and that's a prospection, that's not obviously an exact number. Our calculations tell us that we have more than 16,000 silos of information in which the information related to the patients of Catalonia is split among. And this is growing. This is growing because of the technologies of the digital transformation, all these different mHealth apps, all these telemonitoring solutions, all these different solutions are somehow splitting the information of our citizenship. And the biggest problem, and that, I mean, Catherine talked about a lot about that, and I liked a lot that a vendor or an industrial partner was talking about this, is that all of this information is stored most of the times in proprietary data models, which are obviously not common, and some of the times some of the providers do not disclose these data models. Our reflection is whether, and before going into the future, we asked ourselves whether a system in which we connect the different electronic medical records, all these different islands of information, with some sort of shared electronic health record, and even with some care process management, whether this is fostering patient-centric care and whether this is allowing us to take advantage of this data to ensure the continuity of care, so for primary usage of data and also for secondary usage of data. And for us, the answer is no. So what we say here is that the current model of information systems that we have doesn't allow us to do patient-centric care, but what we are doing is legacy-centric care. A legacy-centric care has these different characteristics. The first one is that it focuses on the applications and not in the care process. So we are trying to patch or to bridge these different applications to do some sort of care pathways longitudinal, but we are super limited by these applications that are very vertical. If we maintain these applications that are vertical, we need to continue in the paradigm of referring the patient. And we know that each time that we refer the patient, this means a transition. And when we have transitions, we have the risk of losing the patients in the process, and also problems with medication reconciliation and safety and security in general. Dispatching and this interfacing in between systems, it's done throughout a limited data exchange, which also limits at the same time the continuity of care. It perpetuates the fragmentation of the ecosystem, and obviously it's not patient-centric care. So now talking about our vision for the future, and first acknowledging, obviously I don't want you to understand this, this is the technological deployment that we have underneath the shared electronic health record of Catalonia. It's many different systems interacting all together. And most of the times I think, or I'm surprised myself that this is working, because there are so many points in which the system can fail that, well, some of the times I'd say that it's a matter of a chance that it's actually working. And for me, it's something like that looks like this. And this is a tweet from a very well-known CIO in the US that, well, describes his electronic medical record at his hospital as something like this. And that's currently the feeling. So service provider level, the feeling is like this, and the regional level, we also have all these different systems connecting this. And we think that's not the way forward. And we think that that's not the way forward because currently our landscape of applications, it's really, really broad. The business logic is varied in these different applications, and also the data models. That's one point. The second one is that we are getting, all these solutions are getting old-fashioned, especially the electronic medical records. Obviously, we've been doing some updates of the technology, so it's not the same as we had in the 80s or the 90s. But we haven't had truly the time to rethink the foundations of them, and we have been basically patching on top. We were also talking about the limitations of the interfacing in between these different systems, which is done through syntactic interoperability, and that somehow limits continuity of care, and also limits putting at the disposal of the healthcare system all the data. So the granularity of this information, it's low. And I would say that we are here following a paradigm of the minimal common denominator and not trying to pursue exchange of maximal data sets. This is costing us a lot to maintain. This is not helping us or not fostering the scaling up of innovations, because each time we have an innovation in a certain hospital, we need to have the integration with a new hospital. So we are not fast enough and we are rigid to change. And this is more or less, I'm taking this slide from Rachel Danscombe, who is now Chief Industry Advisor at the Dalus Group, in which she somehow named these 3 generation EHR systems that we I think that we have. We are in between number 1 and number 2, and we are willing to go into number 3. So number 1 is isolated systems. So when we moved from paper into digital. Generation number 2 is when we try to have this interoperability among the different islands of data that we have coming from generation 1. And this is what we have been doing in Catalonia since year 2007. And that's what we see, that it's a road that has no end, in the sense that to the current paradigm of syntactic interoperability, it's a never-ending story. We can keep on plugging and plugging and plugging different systems, devices, whatever we want, but this is not bringing us any closer to, I would say, to systematically harnessing the power of this data, because the data remains hidden in proprietary data models in all these different systems, and we keep on exchanging minimal data sets. So what we want to move towards is this 3rd generation EHR that stores the information in an open format and that allows the systematic usage of this data for the benefit in the clinic, so for primary usage, and also the benefit for secondary usage for research purposes. I think that we are in times of change, and for me, there's the conjunctural alignment of 3 main factors. The first one is that everyone has realized about the power of health data, and the pandemic, I think, that has helped a lot into understanding that data scientists should be part of the employees of a hospital. Not every CIO and CEOs understood this. We have also the obsolescence of the current landscape of health solutions. It's been 30 years since we started this digitalization process, and I think that we have not stopped ourselves to think again about a better future. And the last one is that digital is now a strategic priority in all policy agendas, and that there's a lot of money coming, in our case, from Europe to rethink this system. So I think that we should take the chance and this opportunity to rebuild the foundations of our healthcare information system. That's the last before the last one. What we are doing in here is thinking that data is for life and not just for one system as it is now. And by considering this as a principle, as Rachel says, we will start designing and procuring the systems differently. And that's what we are doing here in Catalonia, and not just us in Catalonia, but some other friends and colleagues all over the world. And that's my final slide. And that's how do we see that the future looks like. What we think is that we need to take this chance that we have now because of all these three different factors that I mentioned you before. And we should rebuild the foundations, the technological foundations of our health information systems. And we say that what we need to do is to build a new infrastructure, which should be based on open standards. And our suggestion in the case of Catalonia is that these standards are, it's open EHR, or not standard, but set of specifications. We think that we need to think first on the business processes. So which is truly the business processes, then think about the information needs, then think about the applications, and then think about the technology, and not the opposite way. So the order should be always like this. And with this, we will succeed in achieving the so desired patient-centric care. We think that we need to decouple the data from the applications and to store them in an open format, as I was saying here. And with this, we think that we will finally achieve data to follow the patient. We will improve the collaboration and achieve patient-centric care. And we think that we will, in this way, succeed in scaling up innovations. And yeah, that was it. Sorry if I went a bit over the time, but yeah, hope it was interesting.
Jordi, also in your case, we needed to give you more minutes to all of you. This is my conclusion today, because really it was not by chance that we invited you all to give this perspective. So we are beyond the timing. So I would, while verifying if there is any burning question, I would like to ask you for a short comment, starting from what I have taken as notes, but also coming from intense discussions that we are having when we talk about building the hospital of the future. So we have done a 3 days of meetings, discussions last week in Rome, and I had several conclusions that are very related with what your presentation, because it's about complexity of the regulatory landscape, complexity of a transitionary period, no? Because the European health data space is going to take place in different years. There are in a few years, in a couple of years, no? There are many actions that have to take place while going into that model. We have a complex but very comprehensive ecosystem of solutions and visualization of platform that Catherine has shared with us. And also the complexity that you were even depicting with the picture of the cables now before Jordi. And from our projects, what we have learned is that from this complexity, from the different perspectives, we really need to understand the entry points. The entry points that the industrial stakeholders have with the regulatory stakeholders, with the public authorities or healthcare providers, with the citizens, in order to establish this virtuous cycle of data sharing. No? And you were talking about minimum data set or minimum viable information, no? Jordi, and also maybe others. So my question to you is, how do you see the creation of these entry points feasible, and how, which are the barriers that you are already, and I know that you are already facing barriers because I had some discussions with you during these months on adopting the changes within your organization and then with the other stakeholders. So I would like to have some words from your side, maybe starting from Janusz, then Catherine, and then Jordi.
Thank you, Giuseppe. Yes, I think it's all exactly. I think you summarized everything well. All the challenges and all these needs to transform healthcare. Indeed, there are challenges. As you said, there is different transitional periods for the European health data space to take place. I also agree with you that indeed there is a lot of, actually, if you read carefully the text, it will provide for a lot of implementing measures that they need to be adopted at different stages for that thing to take place. Of course, the limits are strict there in the sense that we want to achieve as quickly as possible these targets. That's why you will see there is 1 year, 2 year, 3 year, but not going forever. For example, I've seen one of the presentations before about the electronic health records having different interoperability requirements between regions and so on. And I was thinking that, for example, with the European health data space and especially creating a CE marking, that at least some of those issues would be resolved because everyone will have to abide by the manufacturers with certain specific specifications, but then also hospitals would be obliged to be buying because you wouldn't be able to find in the market something which is not CE marked, which means is not fulfilling certain technical requirements, i.e. interoperability and so on. So basically everyone would have the same specifications type of electronic health records. And also with the other ways, I think that should boost up a lot of the issues I've seen, a lot of the challenges which were described. I think, as you also said, the European health data space, I think, should resolve a lot of those issues. It will make it much easier. And as I've seen also in regions, in member states where there are regions, and there is even problems between the regions, between the thing, I think, again, maybe this European approach would also help those issues because I've seen also a number of issues there. I think it will also boost up those issues. But I also saw interesting things from what needs to be done within the hospitals and by the hospitals to create this issue. And I think that's also quite interesting to make more links, I'm thinking now, between maybe having even more direct connections and talks with the hospitals, because I think that's maybe something which I was thinking in on the presentations, that maybe even bilateral, let's say small workshops, just to see, also to understand better the work of a hospital. I think that would also boost up our thinking too. I think that's maybe what I got out of it and what we should maybe encourage even more. Thank you.
Thank you, Yiannis. Catherine.
Yes, I think lots of interesting points. If I look, you've mentioned, what would be entry points to think about all of these dimensions for a new hospital or a hospital building. I think I recall I've seen in one of the presentations the need to start from the process standpoint and then cascading which information and which data and which technology and so on. So to me, obviously, there is on one hand the regulatory requirements. That's a given. It's part of the foundation that any new project has to focus on. But I think it's really important to look at, if you are in a new hospital environment, either you have some legacy because it's a migration from an existing hospital and you take something with you, or you have a lot of new things that you need to procure. But at the end, it's always to start from the target operating model. And that's a bit my consulting hat here speaking, but it's important, I think, and it's acknowledged pretty much across the world with all new hospitals I've seen. You need to start with what are your organization goals in terms of how you want to improve care, how you want to be part of your ecosystem, how you want to interact, what care pathway you want to be best in, and so on and so forth. And then you will cascade, the process improvements that you need to transform. You need to then to look at the proper informations, and then you will make your EHR and technology choices. Overall, I would say if you look at the more of existing evolution, an existing hospital. The key will be, how do you deal with the evolution from your legacy? I mean, we've seen the huge amount of legacy, and it's true everywhere around the world. No hospital except a brand new build who has a huge budget can replace everything at once. It has to be a combination, and that's why we believe this platform play is the way to go and is a good complement to build the new, but reuse what you have already and keep improving your processes.
Thank you as well, Kat. So following up on this, Jordi, some thoughts from your side on entry points and change management. I know that in your case, there was the digital strategy and of the Catalonia region for the transformation and change management, if I'm not mistaken, was part of one of the pillars or something like that. Jordi? I cannot see him connected. Okay, maybe something happened. He lost the connection. Okay.
Maybe he lost the connection.
Yes, I guess he lost the connection. Okay, so I'm just sharing with you that as part of the Catalonia region strategy that Jordi was in charge of, was one of the leading person, there was clear reference on the change management aspects. So that's, I wanted to say something on that. So we are reaching the conclusion. I don't know, Sergio, if I leave the floor to you.
Yes, thank you, Giuseppe. First of all, I'm really impressed by the three presentations. I'm very enjoy the three ones, and I understand that they are completely connected to the work that we are doing in some of our projects, in particular in ODIN, which is sponsoring this workshop, these webinars, and as well in Gatekeeper. In this moment, we are immersed in a deep discussion about data federation across hospitals in the pilot project, and then in middle of this discussion, you come in May this year with the European Health Data Spaces proposal. Those is created a really storm within this discussion, because they open a really a new way, a new vision, how we, in practical terms, can be started putting the bricks in order that all the work that we are doing must be compatible with the new regulations that probably will come in few years from now. So everything that you have said, Janos, is really open the necessity to enter in more details and discussion, because you have been highlighting a number of critical issues that you give an overlook of this, but we can foresee behind the complexity of implementing this in a European level. So that's something that will probably, hopefully, will come in the next years, but it will not a very easy matter to manage. The second, I guess that the presentation of Catherine in connecting with ODIN, I think that when looking in our ODIN proposal, we are, I would say, 99%, just not to say 100%, compatible in line what the Catherine is showing as the new generation platforms, etc. So all your pipeline of services are really connected to the work we are doing, and then obviously that will open the opportunity that we are building in this moment with the ODIN Hub and ODIN community to strengthen the discussion, in particular with industries like Daedalus and others. And then it's great. I'm very incredibly happy today after hearing you, because it means that we are not lost. We are in a good working in a good direction as a European pilot project in this domain. Obviously, the presentation of Jordi is a fresh reminder of the reality. So at the end of the day, this is the reality. Even though we can propose new paradigms, etc., but this is the reality of the healthcare system, of the regional healthcare system. I think that Catalonia is not in this respect different to many others in Europe that we are dealing with. So I guess that again, there is a lot of lessons to learn, and then I fully agree with the last remarks of Janos that for sure that the new regulations, the new ways that the government of the European Union is putting in order that they will facilitate the solution of many, I will not say all, but many of the issues that we are facing now regarding interoperability, certification, standardization, etc. So thank you very much for this amazing webinar of today. I'm really, as a coordinator of this webinar, I'm very happy that in ODIN we have produced this event. And then I hope to contact you very soon to continue the work and collaboration with our projects.
Thank you very much to you all, really, and also to the attendees. So we really will continue on that and work with you all in the future, in the near future. So have a nice rest of the day.
Thank you. Have a great day and nice to talk to you all. Bye.
Bye also from Jordi. He told me he had a technical issue. Bye from Jordi. He's sorry about that. Bye.
Bye. Bye.